be presenting today my research project for the CLISOG Research Day, which is titled "Is Body Composition Different in Neonates of Mothers with Hypertensive Disorders?" And this project was done with my mentors, Dr. Kelly Gibson and Dr. Angela Runzi. We have no conflict of interest to disclose. And the background of this is that we know that chronic hypertension complicates about 1.5% of pregnancies, whilst preeclampsia complicates 2 to 8% of pregnancies worldwide. Women with pregnancies complicated by preeclampsia, we know, are also at increased risk of cardiovascular complications. And this is a theory of pregnancy as a window into future health of the woman, as we know that preeclampsia increases the risk of cardiovascular complications such as stroke later in life. So does diabetes, and gestational diabetes increase the risk of complications such as diabetes later on in life. Multiple studies have proven that this is true. We also know from studies that have been done in the past as well that offspring of patients with complications such as hypertensive disorders of pregnancy, including preeclampsia, mild preeclampsia, and severe preeclampsia, and even gestational hypertension also have increased risk of cardiovascular complications later in life. And this has been shown to be true in multiple studies. There was a Finnish national data survey of live births showing that patients in their 60s who were born to mothers with hypertensive disorders of pregnancy also had increased risk of complications such as stroke. And was a theory. This is a theory of fetal origins of adult disease, which was proposed by Barker and who popularized this theory, which states that events during early development have a profound impact on one's risk of future adult disease. So we're talking about in utero programming for future complications. The background to the study is also tells us the fact that birth weight percentiles, which have been used in the past as a surrogate for nutritional status, provide little information related to nutritional status and do not actually tell the whole story. And we know that these birth weight percentiles do not do justice to this story. We also know that body composition is a better indicator as it provides estimated percentage of lean and fat mass and also measures adiposity. There have been multiple studies carried out comparing birth weight, body mass index, and ponderal index to show these effects, but no studies have been conducted using body composition data immediately after birth. Our aim was to compare the body composition of neonates born to mothers with hypertensive disorders of pregnancies to those without any hypertension. And our hypothesis is that neonates born to mothers with hypertensive disorders of pregnancy will have a different body composition compared to those born to mothers without hypertensive disorders. Our study design was this was a retrospective cohort of 10 infants delivered at Metro Health from March 2018 till June 2019. And March 2018 was when we started collecting the data for the body composition, and June 2019 was when we submitted our IRB. So we compared neonates of mothers with hypertensive disorders at term with those who did not have any hypertensive disorders. Our inclusion criteria included hypertensive disorders. We excluded babies who were preterm because this has not been the anthropometric model we use has not been validated in this group of babies. Our neonates were matched for gestational age and delivery date. What we tried to do was match them for the same gestational age and delivery on the same day. However, if we did not find the baby delivered on the same day, we matched them for deliveries a couple of days apart. A validated anthropometric model was used, and we utilized a weight, length, and suprailiac skin fold thickness. This was used to calculate the body fat. The suprailiac skin fold thickness was gotten with calipers and measured in millimeters. And nurses have been trained to do this, and we've compared their measurements with that of trained research nurses. and it was pretty similar. And we have validated this method of collecting anthropometric measurements. We use the Catalano formula, which has been validated in multiple studies. And the ideal or the gold standard for body composition is actually the air displacement plethysmography, which is a PPOD. And the Catalano method formula has been shown to be valid and gives an exact measurement when you compare it to the gold standard. The formula was also built into our EMR so we can abstract the data. Our statistics was we used a Mann-Whitney test for comparing medians, while proportions were compared using the chi-square test. Alpha was set to 0.05 for significance, and this was a two-tailed test. So during this study period, we had 229 study patients. We retrieved this from our perinatal database and from EPIC, which is our EMR in Metro Health, and we compared them to 229 controls who were matched for gestational age and delivery date, like I had mentioned earlier on. However, we were not able to find the complete data for skin fold thickness and percentage body fat for 87 study patients and 79 control group, and we therefore came to the final study population of 142 um, study patients and 150 control patients. And we then compare the demographics of the study population since we could not control for some things like the race, smoking, and BMIs that we know may affect the body composition. We try to control for them. I mean, we couldn't control for them, so we now tried to do the statistics and see if there was any difference in the demographics of the study population. And from there, we can see that the parity, there were more primates in the study population and more multiples in the control. This was significant with with a p-value of 0.003. Age, there was no difference in the age, smoking status, or BMI of both the study and control groups. Um, then we checked for pregnancy complications such as diabetes, gestational diabetes, thyroid disorders, and we found that there was no significant difference between both groups. There was no difference also between the gestational age at delivery, as we tried to match them from what I mentioned earlier on. But we can see that there was a significant difference in the number of inductions done for the study population. Most of them had hypertensive disorders or pregnancy, so we believe that's why many of them were induced compared to the control group. There was no difference in the mode of deliveries, and there was also no difference in the sex of the babies. So we found out that these groups were pretty well matched, and there was no difference in the ABGAS, low birth weight, ultrasound dating, and in the race of both groups. If you look at the box plot of both for the skin fold thickness, there was not much of a difference. This is the box plot for the percentage, and now we exclude the chronic hypertensive, see there was a difference, and the of the percentage body fat remained similar in both instances. Finally, we looked at the skin fold thickness and we found there was a difference. There was 4.6 millimeters in the study group and 4.4 in the control group. The percentage body fat was, however, different, as it was 13.16 in the study group and 11.72 in the control group, and this was significantly different. When we excluded chronic hypertensives from this group, this difference was also similar. The skin fold was not different, but the body fat composition was significant as well. So we know that this was not due to the chronic hypertensives. Finally, we can say that we come to conclusion that the percentage body fat is higher in units of mothers with hypertensive disorders of pregnancy, and this might be responsible for what predisposes them to later life complications. However, our studies is limited by its retrospective nature and will therefore need future prospective studies to confirm our findings. These are our references. Thank you very much.